It's a freewheeling.
Yeah. People are like, well, what's the prep?
conversation.
What's the prep? And I was like, I mean, no prep. Let's just talk. And they're like, I don't understand what you're talking about. I'm like, let's just do it. We'll talk and we'll see where it goes. You never know.
Yeah, I
So
talked
as
to
long
Helen
as you're
earlier,
willing.
and I was like,
Yeah.
yeah, yeah.
All right. Well, that's all right.
Disclaimer, guys, we are doing this with no script. This is truly,
right.
Yeah. Well,
People are always like, I know you did like you did a hard, you have like a whole agenda and you have a plan out. I know you worked hard at that. And someone literally said this to me yesterday. I was like, whoa, I don't do any of this. I don't know what you're doing. You listen to the podcast? And they're like, yeah, let's talk. I'm like, okay, well, I mean, we're not doing that, just so we're on the same page.
Yeah.
Yeah.
Yeah. So, wait, so
yes,
you were in
Emily,
Detroit? Wait a second. I want to know this. Yeah, go ahead, Tina.
I'm from Detroit. My phone number is a 586.
Shut up.
I saw you 248, Ben. I knew you were from the area because I was like, that's the 248. I was like, that's the Michigan guy.
Well, wait. So, did you grow up in Detroit area? Where are you from?
Yeah, well, so of course I'm the typical. I grew up in Detroit, but I grew up in Sterling Heights, like north of the city.
The Heights.
Yeah, the Heights. Yeah. So.
That's awesome.
Yeah. Where
That's
are you
cool.
from?
I live in Royal Oak. I'm not from there. I'm from Midland, if you know where Midland is. Midland north and like 2 hours north. Yeah.
My dad went to Northwood. Yeah.
Oh yeah, that's in Midland.
Yeah.
Yeah, and then
and I'm up in Clarkston. I'm up by Pine Knob. Yeah, so
yeah, cool.
Pine Knob. It's back to it is back to
Michiganders here.
That's right. That's right. Michiganders. And now I'm like currently I'm up north in Gaylord. We have a lake house up here. So
Lisa.
Yeah.
Yeah. Well, and I'm based now. I mean, I'm based in, so I got to work on my accent. I'm in Minnesota.
Oh,
Minneapolis, right?
Yep.
Gotcha.
So,
shopping at the Mall of America. Is the Mall of America still open? And is it the hype that it was in like 1994 when it opened?
I think any mall lost the hype of 1994. But yeah, it's still a thing. It's still surviving and maybe thriving just due to its like tourist attraction.
Sure.
But I mean, the mall I grew up and stomped around is officially being torn down. Yes.
Yes.
So I think the touristiness of the Mall of America, I don't think that's a word, but it is keeping up and keeping strong. So that's good.
Very nice.
I don't particularly shop there all the time or ever because
of the tourists.
Yes, it's a lot. Yeah.
Some malls are surviving. I don't know how. That seems crazy.
Great Lakes Crossing is hopping all the time. Again, tourist business. There's a lot of like Canadian folks.
Well, and I think the post-COVID world, like, it's a draw, especially from the work from home, like go out and be around people. It's one of those things now, and you don't just want to shop online anymore. So,
no, that's true. I do. I like the accessibility. I think of it as like a break from my workday.
Yeah, if we could just figure out the box piece.
I know.
That's like the thing that frustrates me the most, but I love shopping online.
Yeah, the packaging. It's just too much. Sometimes, especially when you get a box that's like this big.
Packaging's
an
crazy.
Item this big in it.
Retail's back though. They keep saying retail's like back in the because people like to go. My friend, I have a good friend Jameson. He's a manager at Barnes and Noble, and he's been there for like 20 years, and so he runs all the New York City stores. They're working. His job this year is to like build 24 more stores. They have 24 stores already.
That's awesome, though.
And what they figured out is like it's the footprint, right? Like a smaller footprint, cafe, a space where it's like people are hanging out, buying books. It's like totally works. It's like that's amazing.
My brother worked at Target in Minneapolis. Obviously, this like the birthplace of Target, so big area. And obviously, there's a craze with Target. I mean, I do love Target, but there's a full-on craze. And so my husband and I were talking, and we're like, we should try to partner with Target and create what's called Bullseye, and it's like a speakeasy in the back of Target. So like it just makes me want to go to Target even more.
That's the greatest thing I've ever heard. Like
it's a brilliant.
Could you imagine how it would improve like their sales, because now you've got a cocktail or two in you, and you're.
But I don't.
Like,
I'm gonna be honest.
all
This
the
might be
moms-
judgy. This might be judgy, but like, is the target audience really the speakeasy audience? I don't know if those are matched up.
they are. Every mom is now
millennial
shopping
moms,
with
yeah.
a rosé or whatever.
I
I'm
mean,
here for
you
it.
get Starbucks, you get your Starbucks at the front of the store, and then you get your cocktail at the back of the store. Sounds like you're going to be gone for a while shopping at Target.
I'm here for it, Emily.
It's brilliant.
I'm here for it. I think, loop me in on the franchise when you do the initial raise. Like,
well, yeah. We got to keep...
Yes. My requirement will be a cocktail named after me. That's it.
Done. And it's recorded, so we have it time-sealed.
Nice.
Yeah, I love it. You can be judgy, Ben, and we'll be in the back of Target having a cocktail.
I'll be with Emily. Emily, now.
Dude, I've been totally wrong on these before. I mean, that could be a total win. I don't even know.
That'll be like, what kind of bourbon do you have?
Well, this is my platform to get Target's attention for my idea.
Okay.
Target could have its own bourbon, or like its own whiskey. Like that's smart. I like it. I like what's going.
They started putting now we just need to add a little daycare section so that you can be safe and responsible by drinking and not bringing your kids. And
it's like IKEA,
right?
Yeah.
Yes,
exactly.
Fantastic.
Exactly.
Maybe you can partner with IKEA and you have Swedish meatballs too. This would be like a little food, little cafe. I don't know how we got here, but I'm loving it. I'm loving every minute of it.
I gotta think of a catchy name for that.
Yes, we should. I'm really trying to think of one right now. I can't think of something, but it would also have to be like hard to find. We have a speakeasy in in Royal Oak. Where I live in Royal Oak, and we have one in Royal Oak, and it's like you have to like call the number. It's in the back, and you have to like let you in. I'm like, okay. I mean, does it have to be this complicated? But whatever. It's the mystique of it. You could do something similar. It's like in the toy aisle. Like you have to like hit a certain toy to get to it. Yep. Yeah, that'd be amazing.
You gotta shoot the arrow at the bullseye.
Yeah,
there's like plastic arrow one. Yeah.
Mm-hmm.
All right.
I love this idea, Emily. Emily, thanks for joining the show. We're so excited you're here. Well, we started with Detroit. I mean, I'd love to hear your background, like where you started, where you grew up, and I mean, because you went to Sterling Heights. So, what school would you have gone to?
Yeah, I was Henry Ford 2.
Henry Ford 2?
The second.
Oh.
It's not Henry Ford, because that's in Detroit. So I was Henry Ford the second.
Okay.
Yeah.
Cool. Well, tell us about how you grew up.
Was at Beaumont.
Yeah.
Which is so exciting.
Sure. So I'm going to pause this. Ben, you're a little, I don't know if like you're seeing this, Tina, you're a little scratchy for me. So you are, that's why I don't mean to cut you off. Sometimes you're cutting in and out for me. But is it for you, Tina, or is it just me?
Yeah, I think I'm used to it though, because when Ben's up north, sometimes things happen.
Okay.
And normally I think, clearly it's my internet. Like, I just take it. I assume it's me.
The beauty of this is that we're recording locally. So the beauty of the reason we use Riverside is it records locally in your machine. So even if it like pauses or don't pause the camera, you just keep talking. And I also am recording a separate better recording. So I'll sound amazing when it comes down to it. And my voice gets much deeper, which is nice for me because I don't have a very deep voice. So.
Well, I just feel rude. I feel like sometimes I'm interrupting you. So it's like,
no, just interrupt. Just keep talking. Just keep talking.
Okay.
Emily, I initially had that problem when we first started doing the podcast. That was one of my things. Like I wouldn't talk so much because I kept waiting for the pause because I didn't want to interrupt. But now I've learned Ben's just keep talking. So embrace the moment. Go with it.
Okay. Well, yeah. So Henry Ford 2 in Sterling Heights, grew up there, and I started the high school had like your senior year you can work a job, like you leave early and go work. So I worked at a physical therapy office right in Troy. And I kept that job for about a year and actually loved PT. So I went to school thinking I was going to be a physical therapist. Worked in a physical therapy office then for many years because you have to get the hours, the clinical requirements. And very quickly learned that the dynamic of my personality and the redundancy of some of that work I did love the direct patient care aspects. Like, I'm a people person, so like seeing that direct impact was really empowering, and I knew I wanted to keep that at some level, but I needed to diversify my day more. So that's what really got me thinking before I pursued that too far down the road, what I wanted to do. So I want more of a business route and policy route. So that's why I switched my degree. I started at Oakland, and then I moved to Pennsylvania, went to Penn State, switched my degree, and got my bachelor's in health policy and administration, and then got my master's in health administration. I did the 5-year program.
Oh, nice.
That's where I started out.
I didn't know you were MHA, so am I. Yeah.
Are you Penn Stater?
No, I went to Virginia Commonwealth University for grad school.
Okay.
But I went to Grand Valley for undergrad, so,
yes.
you know. Yeah.
Okay.
Sweet. Yeah.
That's a fun place.
Yeah, it was, it was fun. I mean, it wasn't much back then when I went to school, and I'm old, so, like, it was just like a prison.
I mean, I went to... But I went to Penn State. I mean, it is a little bubble at Penn State. There's a lot to do, but, I mean, you're surrounded by farmland. So, I think similar feel to Grand Rapids area.
Yeah, that's true. Very cool. So after that, like, what were you? So you got a health administration degree. What'd you do? Because I'm curious to know, like, how you like normal. That's a hospital track. At least mine was.
Yes, very hot. And I was actually just talking to our fellowship family because I have an innovation fellowship at Geisinger that I started about 3 or 4 years ago. And it was so non-traditional because everything that's drilled into you in an MHA is hospital administration. Sure. And I think that they've probably added some flavor since you and I were doing ours around like health plans and the healthcare startup world, because there's certainly been a significant traction in that space. But it's heavily health administration. I was in the physical therapy world, so I thought maybe I'd try the post-acute, and I really was driven. My grandparents, I'm very close to them and was close to them before one of them passed, and I just felt the aftercare and the home care setting could be really dramatically transformed, and it's just so much on the caregivers, and the cost construct didn't make sense. So I thought, okay, I'll go work for a company in that space. And I started working in grants in my master's, and I actually continued that after. So nothing to do with the post-acute care space, but really helping the underserved and like food insecurity. I worked in Harrisburg doing research and helping teach people how to eat on low budget income. So like feeding a family of 5 for under $10, which this was back in 2014. So a little bit lower cost, but I think you could still figure out ways to feed a family of 5 under $10 for a meal or two, relatively healthy. It is definitely you have to really think about it when you go to the grocery store. Right. But I was trying to teach what things you can grab, which are relatively healthy and filling and getting nutrients you need. There's a program at it's called Healthy Blues Family, and there's a lot of food deserts and corner stores availability. Totally. So people would walk to corner stores, but the fresh food availability in those is so I was researching, like, how do we get more fresh food in corner stores? And I really loved that, but I knew what I wanted to even diversify more. So I did end up working for a company in the post-acute setting. They did long-term acute care hospitals as well as rehab centers. And I was working in their strategy as well as their analytics team. So I was helping with EMR implementation and kind of bridging the gap with the analytics team where the post-acute setting, it wasn't a Geisinger or a bigger organization where they could afford or even made sense to have an Epic. So, and most EMRs at that time were really geared toward hospitals. Yep. So, you kind of had to create some customization layers for the post-acute care setting to make it work. For federal reporting, throw out some random acronym, but like IRF-PIES is the thing that you have to record from a quality standpoint. And so I was helping to kind of build those from an analytics standpoint, and then how they grow based on their territories. So I really liked the ability to kind of create two really different parts of the organization and create a job out of being within those two realms. I worked for the CEO and for another individual that gave me the ability to really learn all aspects of the organization. And I was enthralled by the diversity of being in every aspect, and knew that wherever I took my next path had to be something that would allow me to help transform an organization. But, where and what that definition was, I had no idea. And so that is when I got a call from, I was talking to one of my friends, now I call her, but she was my teacher in my master's program. I was just telling her how much I wanted to do and grow within these ecosystems. And I said, I know the post-acute care world now, but there's so much continuity, the transitions of care from the hospital system and impacts, that I want to see it as a holistic structure in one of these integrated delivery systems. She was kind of keeping an eye out for me, and then she's like, hey, you have to meet this woman, Karen Murphy. She's looking for somebody to start up this innovation institute. And I met Karen, and it was a 5-10 minute interview, and it was terrifying. And I was like, I have no idea what this role means. Like, it's a manager of innovation. Like, what are you doing?
Wait, where was this at? What organization?
It was at Geisinger.
Oh, this was at Geisinger. Okay,
yeah. I think this. So I worked in the grant space, in the post-acute space, and then I jumped to Geisinger, and I was like I was thrown off, because I was like, this is uncomfortable because it's building something that I'd never done before. But she was just so inspiring, and I believed in her mission. I was really excited based, like, the construct of what Geisinger had built related to, it's health plan, it has a medical college, it has a nursing college, it has the system, it has partnerships in the post-acute space. So back to that, like, search for the continuum. I mean, there was an opportunity to learn it, and, learn from somebody like Karen. And the more and more I got to know her, I knew I made the right decision. But that was really what jumped me into innovation. And here I am today. It's over. Well, we're at my 6-year anniversary at Geisinger. Wow. So. Yeah.
So what were they trying to innovate on? Like, when they started that, what was their thesis? Like, what were you attracted to by the role? And what was it that, like, it's like, hey, we're trying to do this? Like, I don't know. Like, what was the thing?
So one thing that I learned, if I reflect back, is actually some of the pieces of our thesis are still running today, because that's how complicated they are to solve. They were not going to be solved overnight. And so I don't know that I've recognized, like, I don't know that attracted me to the role, because I don't think I appreciated the complexity at that time. So what I thought
things, right? It's like, like, this is going to be innovative. We're going to do fun things. We're going to solve all kinds of problems. And it's like way more complicated.
Great.
Yeah.
Oh yeah. Yeah. If anybody could have, this has been so rewarding, but so challenging. And then adding COVID on top of it was, I mean, everybody in their roles had a layer of complexity with COVID. But so in the beginning, there was a thesis around building these verticals within the technical space and digital transformation, really building a holistic digital strategy for the organization, truly redefining chronic disease management. And I can talk a little bit more later about what kind of that has evolved to, but thinking about how to manage comorbidities more holistically rather than episodic, and in a very siloed vertical of condition-based management. So thinking about the person as a continuum, as a whole person care. So not only just their social determinants of health and wellness was one of those verticals we were looking at, but how do you manage somebody that is polychronic, has diabetes, has hypertension, has, CHF, which is common. If you slice and dice and look at your patient population you manage, it's more than likely or not, there's a large population that has more to tell to their story than just their diabetes, or, so I think it was a vision that Karen had to really think about how we use technology, we use our payment constructs and value-based care constructs to be able to build a model that creates this pathway for patients that is as frictionless as possible, but is still retain the quality of care with each condition from a result standpoint, right? Because when you're hyper focused on diabetes, you can start to see results because the person's hyper focused on that. When you add all of these different conditions, think about it today, you may have a case manager for this condition and a case manager for this condition, and they are calling you every day or whatever, every week to check up on that. So, it can be very intrusive and overwhelming that you're just like, well, maybe I just, I give up, I can't do it. Or, and then the engagement rates go down. So we were trying to figure out that happy medium. And when she told me that, I was kind of like, what? What do you, how the heck? So I think that's really, once I dug into that one, I really realized we were looking at something that's significantly complex, because there's a lot of players in this space too, right? You have your provider, you have your nursing staff in every respective department, you have your pharmacy staff, your care management staff. And so when you add all these layers of people who are passionate too about these conditions and about their patients they manage, how do you create that construct to manage it more holistically? So we're working on that still today. We're using, through population health and remote patient monitoring technologies, some AI risk stratification models to help us be smarter about how we're tackling those care pathways. But it's going to be an evolving landscape, especially with the remote patient monitoring. Technology needs to get less clunky to be able to manage them better from the home, and it's definitely better and good today. Like, you can do it, to be very clear, but I think we'll evolve with like the wearable technology and see more like patches that doesn't fall off or lose a reading, or less, human error, which physicians are worried about when it comes to remote patient monitoring. If you're leaving it up to the patient to take the reading, what's the validity of that versus what you would do in the clinic, because you have control over that reading, right? So trusting that data is very important. So a lot of layers of complexity. That was one program that really, back to your original question, drew my eyes to the vision. And is definitely the hype in AI is here today, but I saw value in automation really early on. That was one of my first programs that I said to Karen I wanted to start up within the Steel Institute, and she was very supportive of that work, and so I was really able to build out something brand new for the organization, and that was exciting to me too. I think that one really has been a passion project and really rewarding, because back to, it's not direct patient care, but it's like, I see the value it brings to employees and the value it brings to the business lines, and the gratitude they have for some of this advancement after we get through the painstaking design process. Sometimes it is hard, but that was another one that I really enjoyed.
How do you think, Emily, like, Geisinger's an interesting kind of enigma in so many ways, because it's the middle of Pennsylvania. It's not near a metro area. Trust me, I learned this the hard way when we drove out there this winter. And I think it's like, how do you think it's done so well on the innovation side and gotten to be so recognized for it? Yet it's kind of honestly, it could just be community hospital, right? Like, it's not in like, Metro Boston. It's not Mass General, right? I think, and kind of just set up to be like it's attached to Harvard. It's like, it's none of those things, but yet it's still super innovative, and I think making money. So like, it's interesting to kind of like look at others who have struggled to do either of those things. So I'd be curious to know your thoughts, having come in later to this. Like, how do you think that works?
Yeah, I think, ecosystem, well, you explain, like, you know where Geisinger sits. It was a community hospital. So let's start there. It was built by Abigail Geisinger to serve a community that was like, they didn't have a hospital within 2 hours of the, probably a little further at Philadelphia, Pittsburgh. Those were the areas you would have to go to get some true acute care. So it started out as a community hospital. I think what built just what it is today, and you like drive over the mountain and like Geisinger just beaming out at Danville.
It's like a beacon.
It is. And I think how it's built is one by its reputation and its care, because it's very mission driven. I mean, the people that live there and the families that live there, it's a tight-knit community. Everybody knows each other. And they really do care about each other. So it starts with the fact that people just genuinely want to help others. And that creates a better quality of care. The innovation aspect, I actually think, also comes from that small community. People have stayed around for a long time. So, we were one of the earliest adopters. I think it was 1999 or 1998 of the EHR. So we have a ton of data that shows very patients who have been within the area and used our services for decades. So we are able to really look at that and build products and build programs that make a difference in the longevity of their health, because we're not in a highly competitive, we do have competition now more than we did 10 years ago, but as it's grown, it didn't have a highly competitive environment where it was very much reactive.
Right.
And
Right.
So we were thinking about sustainability and patient experience over a longer period of time than just that point of care visits. And also you saw your doctor in the clinic, and then you're at a baseball game or a soccer game, and it's likely Dr. Jones is at that, but has a kid at the baseball because the community is so small. So I think there's these are my views of kind of the system, but it is a very mission driven organization. And I think that's what I love so much, is like, it's cool. They invest in the things that we think will advance health, but we're investing in those things based on what makes an impact with our patients, not just investing in the shiny nickels. And that's very easy to do sometimes.
That's interesting, because you're kind of like set up for an ACO model just by sheer nature of proximity of everyone. And that you don't have, you don't have a lot of competition. So you're like, well, no, this is our patient population we're taking care of. And there's a whole continuity of care there where they're not typically going to go to somewhere else.
Yeah. I think today's environment is different than before, but we have built amazing partnerships too with the local community doctors and practices, and we do have an ACO which has partners in the community.
Right.
That we've really built that structure to create continuity across our practices of care too for patients. And that's what I love about the CMMI and CMS, for creating those types of constructs that continue to advance and incentivize community-based partnerships, and investing in each other.
Mm-hmm. Very cool. Good stuff. Tina, what are you thinking?
First of all, I think like that is what you want to hear, right? That's what you want to hear from your healthcare provider, is like, we're investing, like, you know what I mean? And I think, and maybe like I have a very closed view of what people do here about healthcare, because what I hear is, Ben, I'm just kidding. Ben, ranting, baiting. Kidding.
And everything I say is
I love, like,
truthful and accurate.
True. I know. I'm not denying the truth. I'm saying that's what I'm saying. Like, perhaps my view is skewed, because I think, if we're going to roll the clock back, like when I had children 20 plus years ago, I remember thinking, like, when I met my son's pediatrician, he was a general practitioner. He was not a he was a pediatrician, but he was also like in a family practice. So
Mm-hmm.
the view for me was like, that is amazing. You can see my whole family. So you get a full picture of all of who all of us are, as well as you will see my kid from birth until
Cradle to grave.
20.
Yeah.
Right. So we'll get that. We'll build a relationship as opposed to popping into an urgent care for stitches, or, you know what I mean? Like that was my hope. Now he took what do you call that? A break, an extended vacation, a
sabbatical.
He went away. A sabbatical.
He moved away.
Yeah.
The
Moved
word.
away.
Yes. And then I ended up with a different doctor in the same practice, not the same love, you know, so that all went south. So like for me, what you're talking about is kind of what I would say is like my magical dream medical relationship, right? Is that, so kudos, like, well done. Let's write that children's book about that.
Yes.
Then, but secondly, when I was listening to you talk about the innovation piece and how, you know, you're solving complex problems, like I was wondering how you measure success in that space. Like, how do you, at the end of the day, realizing you've uncovered 5 additional problems that go with the problem you're trying to solve, like how do you kind of find your own fulfillment and benchmarks so that it encourages you to keep going rather than getting frustrated and dropping out?
Yeah. Well, I think so there's 2 questions there. How do you measure it, and how do you measure it well for the organization? And then to your point, how do you measure it for yourself based on the fulfillment of your role and what you're doing? So I think like at the end of the day, money drives your mission too.
Sure.
So you have to make, you have to make things meaningful, make business sense. As much as I would love to have an endowment that just allowed me to do things that were meaningful and didn't make business sense.
To
well,
fund
that 10 million didn't
book.
work. We'll see it.
Yeah, we do not have an endowment, so we are a business and we have to run, and so we're measuring against, those financial metrics are important. And I think the other piece of that is the quality and how it, so everybody's like, how do you measure innovation? Well, because it's innovation, everything is so different. So I don't necessarily have these perfect roll-up metrics. I think the perfect roll-up metrics, which I don't think get to the heart of why we do the program, so I don't necessarily like to talk about these as being like the only thing that matters, but it is the financials. So, your revenue, your cost savings, your avoidance. It is also looking at, and a big thing that's been an emphasis for our team is how many hours can we save for our employees, our members, our patients. And there's multiple strategies which are tackling that. And the way we're quantifying it differs based on the program. But, our digital solutions we're building really have to show and draw back to, are we able to take away that administrative burden from our employee and give them time back to do other things, or give them time back with the patient? Because, when we truly think about value-based care, the goal is quality over quantity. So taking away that, it's not, to be clear, this is not specific to Geisinger, but how do we take away that RVU structure and really incentivize, back to your point, the building of the relationship. Take 15 minutes of the meeting of the appointment to get to know your family that you're going to be treating. And so right now in many health systems, I don't think that's necessarily incentivized. But it's amazing what you can learn from people when you just talk to them as a person rather than checking off the boxes. So I think the goal would be to get to something like that. And so that's why we on the innovation front are so dedicated to drawing out unnecessary things that they have to do that can be automated or can be enhanced through digital capabilities, and then enrolling that up to see how many we've impacted across our initiatives. I think personally, though, we're gonna ask something, Ben.
Well, I was going to tell you a quick story. You said on that whole concept, it's like the doctor spending more time with you, right? I was talking to my mother-in-law who's in her 70s, and she's like, her family doctor, who she's been with for a long time, is moving to this model of concierge. And she's totally pissed off about it, right? And I'm like, but Deb, I'm like, it's you. She's like, I'm like, how much is it a month? She's like, well, I think it's like $200 a month. And I was like, shit, like, I think you should do that. Why wouldn't you do that? And she's like, I mean, I'm not, why do I have to spend that money? I'm like, because he's going to spend more time with you. He's going to cut his caseload down. He's going to limit the number of people he has on the total for his total practice. And he's going to be fine. And you'll have more time with him because they're ultimately, like, he won't be, like, held to some standard. She's like, how could you, I don't know. I don't want to spend the money. I'm like, you have the money. So, like, I'm confused why you don't think there's value there, right? Like, it's, like, there's total value there. You don't want to be a doctor. She's like, I don't know. I don't think I want to do this. I'm like, okay. But I'm like, that's where people are going because ultimately the doctor can't make enough money. They have to see a ton of patients, especially a GP or internal med, right? Like, they have to see so many patients to make it even work.
Yeah, we have to be careful though with, I mean, love that, right? It's to your point, like, love the ability to have
they can't
that
all become
privilege
concierge.
to
That's my whole point, probably.
Right,
But
right.
yeah,
Exactly. Like, I mean, well, the issue too is like more and more of them want to drive towards that, and there is a level of individuals who have that ability and financial well-being to afford that, but it only drives, back to the access problem we have today in physician short. I mean, we're coming into a pharmacy desert, a physician and nursing shortage. So I think, we're even seeing, especially after COVID and during COVID with everything that happened, less and I shouldn't say this is not a fact that I know for certain, but I feel like it's a common theme where people are having a shortage of their clinical provider groups, clinicians as a whole, not just providers. But so I think, it's amazing to think about these concierge models and what they can truly do for care and for people who really need it, if we had enough of them in general.
Well,
that's where I balance that.
Don't you think we're really becoming a more expensive version of Canada at some level? Like, I'm always like, I've been thinking more about this, and it's like, well, Canadian medicine is like, everyone gets it, but the reality is what's happening there is the people that have money are paying out of pocket and having this concierge type work. And so I'm like, that's basically kind of what we're creating. We see this kind of holistic doctor, functional medicine doctor, and she's amazing. But like, everything is basically cash, and half the stuff she does is like experimental, like the tests. I just had a fight with Blue Cross on this, and I'm like, what the heck? Like, how come we don't pay? Like, we see this as experimental, and I'm like, so we don't cover it all. We don't even discount it. I'm like, it makes no sense. You don't even have an appeal process. Like, nope. Okay, well, I guess it's whatever. I didn't even know it was an experimental. But that's I don't know, I feel like that's a little bit of what's happening in the U.S. It's just way more expensive to pull off. Because if we just went social medicine, we thought it would be a lot cheaper.
Yeah. It's a good point, though. I think the whole transparency of what is experimental and what layers are coming out of pocket versus because I always do that math. Like, right, you pay your out of pocket and you pay your premiums and your monthly. And I'm like, wait a minute, the math isn't mathing for me. Like, when I start to add it up and the month, but what I pay in the month and then what I pay from the visits, I struggle sometimes. But
no, it doesn't. So it doesn't add up. I mean, it's hard. I think, like, I was just talking to my friend, and he just had unexpected medical stuff happen to their family, and they have they have decent coverage, but he's like, I got $20,000 in medical bills. I'm like, 20,000? Yeah, I mean, that's after his deductible. And he's like, there's this thing called co-insurance? Like, I didn't really understand, like, what it was. And I was like, yeah, dude, it's real. Like, you should have been on a high deductible plan, because then at least you would have been 100% covered after, like, 10,000. He's like,
certain
what?
out of pocket, yeah.
Right, like, he had no idea. And I'm just like, this is the problems. Like, people just don't understand. I did this post on LinkedIn, I don't know if you saw yesterday, but around the whole... they're signing the bill that gets rid of medical debt as, like, can go on your credit score. And so...
Oh, really?
Yeah, which has kind of been in the works anyways for a long time, and they had reduced the impact on it. And I'm not saying it's like that, that's a thing that's like a real driver for people to pay, because they aren't paying now. So there's like, let's get that out of the way. But it is interesting to kind of, like, what I said on there was like, we've created this system in which this, like, because there's a bunch of studies around even a $5 copay for a physician office visit, will reduce the amount that people use it. If there's nothing holding you back, you'll just go all the time. Oh, I got a cough, I'm just going to go all the time. A $5 copay,
Right.
you remember these studies like in grad school, like it will reduce the amount of utilization. So that was the original intent, is that like they have to pay something so they feel like but now what it's become is just the way to shift costs. And so like my argument's always like, why is it the hospital's responsibility to collect something that the payer and the employer decided upon? We didn't decide it; they decided. So, but we're responsible to collect it for some unknown reason. I still have no idea how this happened. You know, like we look back, like we didn't invent this? The insurance invented it for the employer. So it is fascinating.
I never thought about that way.
Mm-hmm.
So I'm curious to your take on it, because that's something that we've been debating in like rev cycle circles for the last 6 months or so.
Well, yeah, I think to your point, how much I know we pay on collections, and like you lose. Why are we the one that's taking the cut against what we can't collect? When, to your point, we did. I never actually dug into that piece as in depth. I know from you living and breathing revenue cycle. Very much agree, though, in the construct of what the employer and the health plan is. Why is it falling on the clinical system? And I think I struggle with, so copays in general are challenging because there's not an easy understanding of what's going to create, like, I know when you, like, your PCP, maybe, your general provider, yes, like, that's the most utilized thing, but I shouldn't have to, like, open a book and go through, like, months of searching and reading. Even as I think, educated individual, sometimes I struggle navigating what the cost construct would be to do and use a certain specialist. And to your point, when something falls out of normal practice and becomes a experimental thing, I think how could we simplify that is a really interesting piece of like even the charging for messages, like the MyChurch messages piece, like they're trying to limit that as an engagement act because they're just overutilizing it.
There's too many messages now, so they ignore all of them.
Right. They're taking away from the in-person visits because people are having to answer the messages on the MyChart. So it's interesting in how I feel like there's a way we could model it or even use the technology in a better capacity to look at the services and how do we normalize the costing and just take more risks associated, but and give a little bit more blanket to the cost.
Well, because you're ultimately like you're going into negotiation with a payer. What you don't know during that negotiation is you're going to get like, hey, we got this 10%. Like I've seen this many times where it's like the managed care people come back like, we got 10% increase. You're like, sweet. Little did you know they've already passed like 15% of that on to the patient. So ultimately the health plan's winning every time. Like you don't even know the game you're playing. Like my always thing is like, you don't even know you're playing the game. They already won it. So it's like you're playing a game that they already won because you don't have the real information of and so then when you send a bill, because right now, like on a typical, you probably don't know these rates, but like on a typical insurance rate, for what insurance owes me, let's say they owe me a dollar, I'm collecting, even a terrible hospital is collecting 98 cents on that dollar. When I had to take that dollar and give it to a patient who has insurance, I'm going to take out pure self-pay altogether, like just forget that. It's only really 35 cents on the dollar, depending on the market. People with insurance, take out Medicaid, like just people with insurance, they're paying you 35 cents on the dollar. So you went from like 98 cents to 35 cents every dollar they shift over. And so I don't know, I get crazy about it because I'm like, this is wild. Like, and we've done all these strategies. And then, my friend Madi ends up on the New York Times, and like, I had a friend, Heather, same thing. She ended up in the Wall Street Journal, like for like practicing, just trying to collect from patients or bad patients who are not paying you, coming back for services multiple times. You're finally going like, we're not serving you anymore. And then they get in trouble for it. That ends up in the front time, and the front or in a House subcommittee, which my friend had to go like in front of Bernie Sanders like 15 times last year.
Yeah, when they're just trying to sustain their practice.
Yeah, and they don't even
by
understand,
collecting the money.
Right, we're just trying to hey, we're just trying to survive here. We're just trying to collect what's actually owed to us. And people aren't paying.
Right. Whereas any other, you don't pay your phone bill, they're going to come after you.
Right. Well,
right. They just shut it off.
They just shut it off.
No phone for you.
People pay their vet bill,
yeah,
right?
right.
The vet bill because you're paying for Zero, Tina's cat, before you even get services. So you have to pay it.
Yeah,
right.
It's true.
Or dental's the same way. It's like dental's going to make you pay up front. We're going to give you, here's what it's going to cost. Do you want to have it done or not? Simple.
Yeah.
So it was just really complex of an issue, because it's like what you guys are trying to do is capture the patient, get them in the right places at the right time, do everything you can to have the care done in an effective way, but you're also a captive market. So it is an interesting, when you're in a really competitive market, I don't know. The hospital's kind of become an enigma in so many ways, where it's just an entity. There's no relationship.
Yeah, exactly. I mean, and I think that there are external forces, or not forces, I should say, competitors now. Walmart obviously no longer is competing in the primary care space because of exactly this issue. It's hard to keep the doors open when we are just focusing on that single point of primary care is going at it alone. At the far. So kudos to these external players working in this space. But I often we built a relationship with Best Buy, and one of the things I said is this is not for the faint of heart, and it's going to take a long time. So are you willing to invest that time and money? Because this is not your traditional space. And so if you're not willing to invest that time and money, you're not going to succeed, because it's a long game.
It's a long
because
haul.
To your point, it's complicated. Yeah. And you have to, if you're going at it from a very siloed approach and not looking at the holistic, the continuum of care, as well as the financial, the economics behind it, and the ecosystem that you have to be able to thrive in one area to subsidize another area, is a really important piece to how you maintain your business.
Yeah. I had a friend at Amazon Healthcare. She probably left 7 years ago. They've had a couple iterations of what they're trying to do.
Yeah,
they
which kudos to them for keeping. They're trying.
At least they're trying, right? But she left and was like, "I love the people there. I love what we're trying to do." It just wasn't the way we were going at it. Wasn't going to work. It's and then they bought One Medical. So I bought One Medical, which I actually thought was their EHR play, not necessarily the provider play, because word on the street was One Medical had the best physician EHR in the industry, which I don't know if that's true or not, but I've heard the technology is incredible. So I thought this was their play to go after Epic, but I guess not. They really haven't done much with it. Oh, maybe they haven't. It's just all in secret.
Yeah. I'll be really interested too to watch what Suma and the GC folks do to see how they change the game. With I'm a little nervous, but
you think they're going to change the game?
I think. No, I don't.
They don't even know what they're doing. That's the first thing they've ever done like that.
Well, yeah, that's a good point.
Unless you tell me differently, I don't know.
Well, I think, Mark Harrison is part of that group. And so at least and I'm not saying one single person's going to solve it. I think, though, the more we can have people do unique things like this.
Agreed.
I don't think they're going to change the game as an individual group, but I think the pressures that the Amazons and the Walmarts and the General Catalyst investing and doing things, it's changing the game because it's creating different dynamics that allows and forces not only us as systems, but the government. It catches their attention, and we have to start thinking differently. So that's what I think will chip away at the problems. I am an optimist through and through. So I go through my days of pessimism, but at the end of the day, I live in a mission-driven organization too, so that's part of the thing. But I think we're gonna figure it out because we don't have a choice. To be clear, I have to be an optimist because the other side of it is a really I would be in the dark in my
dark
right
rabbit hole.
what it's going to do? People are going to die if we don't figure this out, and people are dying, and people aren't having the appropriate access to care. And food, like the food is medicine space, it kind of squirrel all over the place here.
Yeah.
So yeah, like we have proven out that food does make an impact. It's back to those social determinants of health, but like, where's the incentive structure and the economic structure to really create more programs like this? No, they're grant funded. They're through the state, and so creating scalable things that really make a difference across a significant population versus a hyper focused one that has the appropriate. So those are things that I think we need to keep doing and investing in to slowly change the game. It's not going to be a big thing.
No, I agree. I agree 100% on what you just said. I think there's a couple of things. One is, I think we have to embrace that failure is okay. If we go try new things, it fails, keep trying. Because right now we don't have that mentality almost anywhere.
No.
And so that is one thing I think is true. Right? And so, like, the other thing, I'll tell you a quick story. Tina knows the story. My friend Tommy, we had him on the podcast many years ago. He ran a health plan. He built a health plan from scratch, Medicaid HMO. This is incredible. He doesn't know anything about the business. He's just an entrepreneur. Tommy's genius. So he goes to Washington, D.C., which is typically not a very difficult place. It's political. They only award 3 contracts to Medicaid HMOs. He gets it with no company, didn't have any track record. It's incredible, right? So he gets it, and he goes, we had the first year's terrible. Can't get claims out, we're like, but we're figuring it out. We finally figured it out. He goes, and then I just figured out the game. And I figured out, this is fascinating. He goes, I figured out the game of how this works. He said, I basically figured out that like my 5% of my population is costing me 80% of the total. And he goes, and that 5%, I just got nurses on the floor, and I just had them manage, like, hey, you're getting so-and-so to the appointment, calling so-and-so to take their meds, like, he goes, because I knew if they hit the ER, it was $5,000, but it was really $50,000. Because they'd go, if they hit, so if he's like $50 copay or office visit to a $5,000 ER to $50,000 inpatient stay, right? And what he figured out is he just managed the hell out of those people, like you're saying, on the health plan side, right? This is incredible. And then what started happening is his medical loss ratio was so low, even though he's paying claims like within like 12 days or something, faster than both his competitors. What they were doing is they're comparing each other, and what they would do is compare the medical loss ratio. And his medical loss ratio was like 52 or something. It was like so low that they were thinking he was doing something illegal.
Yeah.
Right? So he's like thinking doing something illegal, and he's like, I'm not doing anything illegal. I'm literally just managing my people.
Really right?
Which is incredible.
Yeah.
And then guess what they did? That's what they ended up having to do to him. They forced him to sell his company. Forced him.
Why?
They're like, you have to sell it because you can't own it anymore. We don't trust you. So it's like a political game, right? But like, he ended up doing well for himself. He did fine. But I found it fascinating. Like, he actually figured out what to do here. So imagine if he could do that like on a larger scale, combined with the hospital, and they could actually work together to manage their patients. This is what I find fascinating. I'm like, this can work. We can get to like where insurers make money, and we make money, and everybody wins, and the patients win because we manage the patients that are costing us and getting into places they shouldn't be. Like, how often is that? Well, because it's just, I don't know, I found it fascinating, like, that story. I always go back to it.
Well, and it's managing the patients that they cost us a lot because they have a lot of things that need addressed.
A lot of things going on.
And I think the point, they need the help.
Mm-hmm.
So I think that's the piece. And the other thing you touched on that you said he did, I think, is like, these are things that are just not as a part of like a clinical side of that you're thinking about how to get somebody. You're not incentivized to get them to their appointment. You're paid for the appointment. So the transportation aspect of it. So back to those social determinants of health and where a health plan is incentivized to help with that is really important to changing the dynamic of their health care, I should say. And then overall, when they feel like they have the security and those Like the basic Maslow's hierarchy of needs. It's not rocket science, but we need to solve for, like, do you have security and a roof over your house, a roof over your head, and, you know, food to feed. Like those are the fundamentals to really getting you back to optimal health, or at least managing a condition to the best of your ability. And those are things which are not necessarily at the forefront of our incentive structure.
It's the incentives. At the end of the day, it's like the incentives to like work together or figure it out. And right now our incentives aren't aligned.
Money drives the mission. Yeah, incentives are like, money drives the mission. At the end of the day, this is a business. We are not in a socialistic, care model. So we have to be able to run and sustain ourselves.
Yeah. Well, Emily, this has been great. I don't know, Tina, do you have anything else for Em? Just
no,
Emily,
I'm
for us?
I'm
Do you have
just
questions
delighted.
For us?
I know.
Well, Tina, I don't know I didn't do enough for reconnaissance. I know that you're in the communication side, but how did you and Ben meet? Like, what's the dynamic here? Uh-oh, did I lose you?
I did, but it's okay. I know no one ever knows. I'm a mystery. I'm an enigma. I like to roam around.
You're not a mystery.
Yes, I am. Damn it.
Okay, you're a mystery.
Well, typically I work in the marketing space, the event space. Like that's where most of my stuff is. I met Ben.
Are we losing her? She's gonna keep talking, and then it's gonna feel like she's. I'll tell the story then, because we lost
working
Tina.
in revenue cycle. Oh, we lost me again.
We lost you, but Tina and I met.
You tell the story.
She ended up writing a book for someone that I worked with. So Tina's written multiple books. If you didn't know this, New York Times bestseller as a ghostwriter. Boo. And she's really good at it. And then she was doing some marketing work and worked at a company that I started called HealthRise with a few other people.
No fair.
And that's how we met. And she's been in the PR space, and she does and now a lot of event stuff. So she helped me with my leaders forum, like right off the bat. So sorry, Tina, if you're back, you can tell me the story.
I'm back. Sorry.
What's the leaders forum?
Oh, Ben.
Why am I not in this leaders forum?
Yeah, why is Emily not in leaders forum? Why haven't you invited her? Wow. So twice a year, Emily.
My easy cop out is like it is geared towards rev cycle leaders. It's like Bob's in it.
Oh, okay.
Solve big problems. Yeah. Solve big problems.
Yeah. Yeah, solve big problems.
I see. Fair.
So I started that 7 years ago, and it was like my whole intention was, could I gather some of the best leaders in the country in a small format, limit the number of vendors, and just have real conversation. And so 45 people.
Best.
Yeah, Emily, that's the best. And honestly, I want to say the last few, we've really honed. I don't know, something's happened in the last. I don't know if it's Ben's pure energy. We've really honed it, and you can feel the change in the room. It's amazing.
Uh-oh, you lost her again.
You should know her internet's. It's like it's fine. No, I do think we've like honed it in. Like we lost you. I think it's interesting. It's just kind of like as it's gone on. We've done our 10th event just this fall or this spring, sorry, and how much it's changed and how much it's like. I think more about. People feel alone. Like, I don't know about you, but like rev cycle people feel alone. Like, even though they're in a lot of groups, they go to this big HFMA thing or whatever it is, like they're not really communicating where things are not working. Like we kind of strip everything away. We had the cell phones go on the back for the day. Like, we're gonna strip away the ego. We're gonna try to dig in and like we're here because we've got to be able to support and challenge each other. In a way that, like,
it's bullshit if
your team isn't going to do it, right?
Out.
Yeah, and you get that a lot. Like that, most of HFMA and Beckers and stuff like do presentations. Like, okay, you guys are great, like, but that's not really interesting anymore. Like, what I want to know is the failure, and what I want to know is what people are like stuck on, and like, hey, I can't talk to my CFO. Like that, those are real issues.
Let me figure out. I 100% agree. I think that's amazing. I think the more forums we have, and I think the small group setting is like nobody wants to be in a large group talking about these problems. Like, give me like little subgroups where I can, and people who are similar structures. Like, nobody wants to hear from a Geisinger if they're like a single community hospital,
right.
and
They can't
how we're trying to solve the problem.
Right.
Yeah, like great, good for you. I don't have the resources to do that. Like, give me something more realistic. So I think
was at
honing into on like
totally. I was at a Becker's panel once, and like this is a classic of why I do this. I was at a Becker's, I don't know, one of their meetings, and it was like a panel, and on the panel, I swear to God, it was like access leader for Providence in Seattle, right? Who is $27 billion in his revenue, is enormous job, and out of the industry, he's incredible. And then right next to him is a woman who's at Vail Medical, like, or whatever, some like Aspen or something, where it's like that's not a real world. It's not even real world. It's like a different. Those aren't even like similar situations in any way, shape, or form. Like, it's not even a typical community hospital. It's like a, like high-end premier. Like, they could do anything there. So I was like, why? And then the other people didn't have any. I was like, this is a terrible setup. Like nobody wants to. I'm sorry, but nobody wants to hear from the Aspen person, because that's not a real world situation. No one's gonna have that where everyone's ultra rich. It's like, that's not.
Right. Exactly. Everybody can pay the concierge fee. The $200 per month is no problem.
Right. It is a concierge fee. When you have a concierge at the hospital, there's probably something else happening.
Yeah.
Anyways.
Right. Oh, yeah.
Well, Emily, thanks so much for doing it. Yeah. Yeah, I appreciate it. Great getting to know you, and I'm excited about what you guys are doing, and maybe join us again in a year or two and see where you guys are at. Love to see it.
Yeah, thank you. And Tina, nice to meet you.
It was nice to meet you.
I love that the Michigan days. If you ever, I'm back in the local Detroit area. I know you guys are a little north now, but let me know if you host any get-togethers there, man. I'm in.
All right.
Are you moving back? Are you coming back?
No,
but I go back. If she's here.
I stop in. I have family there. I mean, I stop in all the time. I see my family, but
we'll go to the Target and the Bourbon Room in the back of the Target.
The bullseye. The bullseye is what it's called. The bullseye.
The bullseye.
Yeah.
Amazing.
Yeah, I gotta go.